Good morning, all. My name is Priscilla Okunji, and my presentation will be on outcomes of patients with diabetes and myocardial infarction, which is heart attack, in urban hospitals. And we use electronic health records for the interrogation of the systems. Disclaimer, actually, this is a sponsored project by NIH from a bigger project with Howard University and Georgetown University. But actually, I had to collaborate with College of Medicine in order to apply for the supplement in which I have this. That's why I just want to present it today. It's a pilot project. For the overview, as teachers, we usually give overview, summary of what we are going to present. So for this, we have background, electronic health record opportunities. Yes, we have opportunities, but we also have challenges and leverages. We also have methodology and the abstraction analysis. Results include the demographics, the variable disease categories and disease outcomes of the disease categories. Then we have conclusion, references, and acknowledgements. I have to be fast. So, well, for the background, EHR, known as electronic health record, is what we use in hospitals. Sorry. And in hospitals, actually, nurses are doing a lot. How many of us are nurses here? How many? Anyone a nurse? Yeah. I also have, yes, a nurse. So we have 3 of us. 4, they are knowledge workers. All the vital signs, history, on admission, we enter a lot into electronic health record, which was implemented 2014. And any hospital without this now cannot receive any referral from Medicare and Medicare. So it's very, very important, but it has its own challenges, which is about the interoperability, making them to come together rather than in silos. For example, the admission data set, the administrative, the outcomes, and all those, they need to come together so researchers can use them. So it is imperative that we use this. Instead of going to the bedside, we can use already collected data to make an informed decision. That's where EHR, meaningful usage, is very important. So for this, we applied, especially for the minority faculty that have the skill in informatics, to use this opportunity to go into the system in their hospitals to extract some variables that will lead us to do certain research and to have certain outcomes. An example of data flow is the Mester Hospital. They have 10 different hospitals within the institute, because it's a research institute. So we collaborated with Howard University, and up to that, you see, there are different, only that I can't even use anything. Can I use mouse? No mouse here. Okay. So we use, I can do this. Which one can I use? I just want to show this diagram because it's very, very important. Did you want to move it? Yes. No, just to show something within there. I can't.
Yeah, no. Why don't you just go over?
Oh, there you go. Okay, there you go. For example, you have Mesa Montgomery Medical Center, Mesa Southern Maryland. These are all in Maryland, but these hospitals have silos in their system. So if we can get them together, it helps a lot. Because the problem with EHR is getting them together, that the interoperability aspect of it. So this hospital can be converged into a clover leaf, and they can also be used by physician anywhere where they can access the data, data for their patient to make certain decisions. So what we did, just have two groups of hospitals, Group A and Group B. We use their Health Information Exchange and SML to get the data together in order to find out, to work between hospitals to know if it's even feasible. Because in DC area, we haven't seen such study before. So this is a pilot to know actually how it will work. And for that, when we get them together, we categorize them according to the patient characteristics, disease categories, and the outcomes. So for the CDA, which is Clinical Document Architecture and Templates, it's like a puzzle. They are scattered. But if you can code and know the number of the diseases, you can be able to get the data together and make use of those rather than collecting data. They have already been collected. So if we can do that, it's really possible for us to use it. So we use ICD-9. I know we have ICD-10 now, but for 2013, the data we are collected using ICD-9. So for the ICD-9 for diabetes, we use 25,000 coding, and myocardial infarction, 41,000 coding for all those admitted in this hospital for 2013. And what we did, we cleaned. I worked with statisticians from both Harvard and Mester Institute. And that helped us to usually clean, do the analytics and statistics, both univariate and multivariate analytics. So in that, we use also IBM version 25 of SPSS. So what's the result? For the demographics, looking at that, you see the male for the diabetes only, because the diseases were categorized into three. Diabetes only, heart attack, myocardial infarction, that's another name for that. That's two. Then number three, we combine both to know actually how many of them were admitted. Looking at this, the males, 1,593, that equates 59.4% were admitted. Then for the MI only, we have the females, 53.8, higher than the male. And also for the combination, we have more also in female, 567, which equates 51.55%. And for the years, look at that. Of course, it's known that those with combination of these diseases, they have more than those with only MI, than diabetes only. Look at the race. This is very, very important. We have to know this. For African Americans, we had 86.1. For diabetes only? Of course, you know why that is. That is, it's in literature. So this research is really what's going on. We all know that. MI and also combination all across the African Americans, we have more that when you compare them with other ones. So we also did some variables like the BMI, systolic blood pressure, diastolic blood pressure, LDL, HDL, to know actually what is really going on. If the literature is really telling us, well, I know when you collect that data, you can actually meticulously do that. But extracting them from the system is another ball game. But that is why we are piloting on this, to know actually if it's giving us to validate what we have in literature and look at the p-value, the significance of this. For the age, of course, when we are getting old, that's when we have all those chronic diseases. And look at the BMI. Of course, with obesity, that comes with what? BMI being high. You also have hypertension and heart attack. You also have systolic. The upper part of the fraction is also contributing to that. But diabetes and HDL, they are not contributing. Look at LDL. That's the bad cholesterol. It's also doing that. All right. Now we get into logistic regression. Here we also have, this is where we have to match what is really affecting what. For when the combination says significant, MI significant, gender, it's not significant. Race, it's not significant. Then age is correlating with our result. So in this case, we already know that we collected over 4,350 patients data, and for African American, they are higher, those for diabetes. And for all categories, they are also higher. Just as I explained, age, LDL, they contributed to this. And also systolic blood pressure and BMI, they contribute to that. However, we do not have that for DBM, that's diastolic, and HDL. Now, let's go into the outcome, which is mortality rate. We did logistic regression to find out, actually, for these three categories, which of them really impacting mortality rate of this patient. And we found out when compare DM, that's diabetes patient, that's MI patient, we are 3.8 times more likely to die of this disease than those without that. And 4.2 times when this disease are combined together. So the DMI, when you have both diabetes and MI, you can actually die more than any other person having them separately. So in conclusion, the analysis of multi-system data set from urban hospitals in DC would enable investigators to specifically answer pertinent research questions that may lead us in using best practices among the hospitals. This is the first time it's been done, and finally, the results of this project may be used to guide resource allocation to further enhance and convert data through coding into meaningful use, rather than rewinding the well of collecting those data. We already have that. Actually, I'm trying to do this in Nigeria. Legon system, they established they call that Nigerian EHR. They already implemented that 2013. So we are going to do that do this research in Nigeria as well. Okay, sorry, with this regard, they gave me an award in this, and also I'm so happy to present to you that this is my publication, Nursing Informatics, because it's a new thing coming in. So it was just really published recently. So it will help us to, because nursing, we are still a little bit lagging behind about informatics. So, but informatics is being both undergraduate, graduate, doctoral level, you have to have that across. It's very, very important. And other ones. Thank you so much.